Hey, Section 3. I hope everyone's doing well after this week. We had a lot of information to go through between the cats and the articles and the videos and the different presentations. So I appreciate everybody bearing with us this week and trying to get through all the information and participating. We're going to dive right in. Hopefully, I was able to get to as many people as possible this week, and nobody felt too neglected. With the cats, I tried to sprinkle in stuff in the different cats. I may not have gotten to everyone. I tried to get to at least half of the groups in each of the different groups, trying to interject my thoughts on what was happening. I was traveling this week in Washington D.C. Had a great time out there, but I wasn't able to perhaps get to every person. In the course, and so I apologize if I didn't get to you, but for the most part I thought the cats all looked really pretty good. We did a good job of analyzing what is important in the literature, of picking out some of the things that you would be like kind of sketchy about. Everybody seemed to have a good grasp on what was happening. So in regards to that, I'm just going to quickly kind of give you my 2 cents on and kind of the consensus too. So in the alpha group, they had a thoracic spine manipulation RCT for rotator cuff tendinopathy, looking at the kind of the effect. And certainly it was, one of the criticisms was it was short-term relief. The sample size was small, and it was a homogeneous sample size. So a lot of people said that, that I don't know if they could generalize it to their patient population. With rotator cuff tendinopathy, are we seeing these people being more like 40 and 50-year-olds or even 60-year-old patients that we might be seeing? And while that all may be true, what I would say is that oftentimes we can be fairly nitpicky at some of the literature and some of the thrust literature, and yet we are not as nitpicky as on other things such as modalities and cross friction and some of those other things that really don't have hardly anything behind them, and yet we still utilize them. So it is good to be critical, to have a critical eye, but also remember that sometimes when something shows some positive effects, why not give it a try? Because, shoot, how long does it take to administer 3 thoracic manipulations? Really no time at all. In the Bravo group, they looked at the effects of 2 different braces, and there was an immediate change. No one brace was better than the other. It's probably worthwhile to consider. There was some banter about was it a neural response versus a biomechanical change? Were we really altering the position of something, or we used to think braces unloaded things. Boy, I struggle with this because I'm not a huge fan of braces. I usually tell my patients braces are kind of like a big hug. Everybody likes them. They feel good, but in the long term, they really don't have much of an effect. With that being said, if you do see immediate change, and even I think it was Blaine who had said that he does a test retest with it. I apologize if it wasn't Blaine, if it was I'm pretty sure it was, who do test retest, and then if you get change, you go with it, and if you don't, then you move on. And I think that's obviously an excellent way to do things. I'm always concerned about cost. Braces cost an exorbitant amount. When I look at ankle braces and I look at knee braces, my skin just starts to crawl because they really don't do anything, and just with a little bit of guidance and a little bit of help, we can reduce it. But if they're in acute pain, you go for it then. In the Charlie group, they looked at an acupuncture study versus a steroid. I certainly don't see a ton of carpal tunnel. As a matter of fact, I see very few, but I do see on occasion some, and I've never had anybody get put on steroids. So I thought that was kind of interesting. Obviously, I'm not the expert when it comes to standard of practice, but I thought that treatment of choice to compare to was interesting. In this article, acupuncture required the more visits. Like I said, no one I know has used oral steroids. There's a fairly strict inclusion criteria, so it may be hard again to get that same group in your clinic. But I beg to ask the question: is this a precursor for dry needling? I think there's going to be a load of dry needling literature that's going to come out in the next probably 2 to 3 years. You're going to see it, and it's going to start with case studies like it already has, and it's going to build up to bigger things. And it would be interesting. Hopefully, somebody does something on CTS. I just don't get enough of these patients. The Delta group had to do the Delta group had to do one that was looking at the treatment of the thumb OA. And man, I don't get a lot of these either, and usually they come in conjunction with another problem. But man, these are such home runs. And if we can mobilize these patients and get they had 12 visits, which I thought was kind of long, and who knows what the long-term effects versus short-term. But man, those people who have those OA thumbs, who we just don't, the CMC, man, to go after those, mobilize those joints, distract those joints. They respond really well. Mobilize that wrist. At 12 visits, I would never treat anyone for 12 visits, but man, 2 or 3 visits, you should be able to shake that out pretty quick. So I thought the treatment approach was spot on. Perhaps we needed to be doing more of this and no outcome tool, so it makes it kind of challenging. All right, moving on to the literature that we talked about this week. So I'm going to start with the kind of the biggie this week that I think a lot of people will take home when you think back to this course. Week 4 is you'll remember the CPR that Wayner did in regards to carpal tunnel. And, I think I asked a couple of people to kind of clue in on, obviously you need to have, or the more of 5 you have, the better you're going to be. But it's always interesting to clue in on a couple. And in this case, shaking of hands, I thought was a really good one. And the wrist ratio, if you have the calipers and you're doing that, that's certainly not difficult to do. But the shaking of hands is obviously just a subjective question. It makes it much, much easier. Some of the different criteria, it's always interesting to see is how less important our objective exam becomes in our special tests. And as some people made comments, they would continue to do Phelan's and Tennell's, and that's all fine and well and good. But remember, if something's been tested, and granted, the CPR has not been validated, so it does still have a question behind it. But when we know that the special tests are really not quite so special, we do need to start to realize that clustering is probably the way to go in the future, as well as these kind of subjective complaints that help us categorize people in certain groups. But with a post-test probability of 90%, man, I would think that you'd want to lean on it, at least until you're proven wrong. The Ackland study, a lot of people were kind of disappointed by this. I don't know. I wouldn't. I find that certainly median nerve mobilizations you should see a difference, but how they incorporated them, tendon gliding, I don't know. In conjunction with manual therapy, like in the Tal Akabi study, I think that's a home run. The nice thing is those exercises were easy to do for patients. I question how they would follow through on how many they had to do. It was a small sample size, so I don't, a lot of people said, I was kind of bummed at the Ackland study. Well, I think splinting as a general rule is probably good if you're really struggling with that whole numbness at night thing, but don't lose too much sleep over the fact that the tendon gliding and median nerve didn't bear out. Whereas this Tal Akabi group, when they are looking at nerve mobilization and carpal ball mobilization, no one was better than the other, but just think what would happen if we would have been able to combine the two. I posed this last question. Why aren't other professions seeking out the best possible answers for conservative care? Now, you guys are scouring the literature. You're searching through PubMed and Google Scholar, and we don't find a lot of OT literature. And I beg the question, why? Why? For the people who get the majority of these, there's been a number of people who've commented that we don't see these. Why aren't we seeing that profession kind of owning this diagnosis if they really want it? Why aren't we seeing them come up with some better options for us in regards to treatment approach? And I don't have the answer, and I certainly am not necessarily picking on anyone, but I do think it poses a moment to ponder what's going on and why aren't they? So I just like to show this median nerve glides. I use this picture to the right very often because I find that when I'm trying to get sliders going, and I use sliders fairly frequently initially just to get things moving, especially in acute kinds of issues. And I find that these different diagrams of this picture off to the right gives me so many variations, and if the patient gets it and they can feel comfortable with it, then I know it's usually a pretty good home run. So from a clinical standpoint, I love this diagram on the right because I use it a lot as far as helping kind of guide my patient as to what is the right amount of tension versus what is the right amount of sliding, depending on the acuity and what they feel. So things to consider kind of moving forward, because I will say that I don't do a ton of carpal tunnel, and so some of my experiences aren't as perhaps prolific as I am with some of the other from the elbow up. Yeah, I posted even to a number of different people this Huff article looking at median nerve mobility. And I do think it's fascinating to be able to see when you put tension on median nerve what to expect. And everybody commented, and this kind of is a nice segue into week 5, but the concepts of regional interdependence, and people talked about how they, whether it be dry needling working from the neck all the way down the arm through the path of the nerve and then down into the forearm, or whether it be soft tissue mobilization or thoracic manipulation, how starting basically, up at the scapula or cervical spine and working their way down is a big deal. So moving into week 5. Okay, so we've got, we're going to have new groups. I'm going to be sending that out attached with the weekend wrap up. So that will be attached to this email. I'm going to be giving you your mid-quarter grades sometime during week 5 as I get all my information together. I've got a pretty good handle on what's happening, and I think I can give everybody some decent feedback on where to go. We're going to have new groups. We're going to have, and those groups are going to be for your group projects. And now bear with me because believe me, I tried to put you guys as close together, but we've got some. You're going to have to be a little bit flexible with the times, and I apologize, but that's just kind of how it is when we have people all over literally the world. So we're going to be moving into that segue, moving into regional interdependence. There's going to be an interesting article that Rob Weiner did about that. We're going to be reading an article from Cleland and Coptiers, which is really, I really enjoy reading him. Michael Coptiers is really good. And then this Strunk article, really good, kind of sitting back and talking, now that we've talked about some of the kind of the major diagnoses that you see for the upper quarter. Well, how does that regional interdependence perspective really take hold, and asking you guys to kind of self-reflect on that. And so you'll want to start to get into getting into your groups. Make sure that you get into your groups, you introduce yourself, you talk about times which are good for you guys to gather, so that you can get that started, because with the time differential, it's probably going to have, it's better that you get on this sooner than later. And lastly, I would just ask, some people are better at getting to your posts sooner than later, and I just make sure that you guys clean up, close out your posts at the end of the week. This week there was some stuff that was left unattended, and we can talk about grades and all that stuff, but in reality, this is really about you guys getting the most out of this course. And when people leave posts unattended, when they're not attending to their original posts and the comments that are left, you're just missing out on good collegial discussion that could help your clinical practice. So please pay attention to that. If you have any questions, if there are any problems, please let me know. Otherwise, we'll see you after week 5.